All right, well, welcome back, everyone. We're going to get started here with our first post-lunch panel, and we're going to hear from a group of Southern California health plans discussing some of the challenges and solutions that they've been working on. And I'd like to introduce them briefly. George Scolari, who we heard from this morning, is Behavioral Health Program Manager for the Community Health Group. I don't think I'll go through this all again, and you'll be leading off?
I'll lead off.
Okay, and then we've got Catrina. My introductions are not in the same order as the seating here. Yes, no problem. Catrina Rodriguez, MSW, and Catrina is the Behavioral Health Program Manager for Care First Health Plan, where she has responsibility for managing all areas of behavioral health care, primarily for LA County, including integration of behavioral and physical health care. Trained as a clinical social worker, Catrina has over 11 years of experience in managing behavioral health care and 2 years in county mental health services. Her accomplishments in program and operations development, strategic business development, project management, provider network development, credentialing, NCQA, mergers, acquisitions, integrations, and innovations are among some of her other accomplishments. Prior to joining Care First, Catrina worked at Beacon Health Strategies, overseeing provider operations, and before that was with Optum United Healthcare in the project management office, and Pacific Care Behavioral Health and Provider Network Management Department. Catrina has a BA in Business Administration from Cal State Fullerton, and went on for MSW with a concentration on child welfare at Cal State Fullerton. We have next Greg Greenwood. Greg is a clinical psychologist licensed in California and Indiana. Dr. Greenwood is a behavioral health director at Care First Health Plan in Monterey Park, where he is responsible for behavioral health care services and plays a key role in the integration of behavioral and physical health care. And he's responsible for the oversight of 2 managed behavioral health care organizations. He has worked in the healthcare industry for the past 30 years, starting out in behavioral healthcare services delivery and the training of clinical psychology interns and psychiatry residents, while an assistant professor at the Indiana University School of Medicine, Department of Psychiatry. Dr. Greenwood joined the first managed behavioral healthcare organization, American Biodyne, in 1986, and in 1992 was recruited by Blue Cross and Blue Shield of Texas to develop an integrated behavioral health care program for Texas state employees. In 2000, he became EVP operations for Value Options. 2 years into his career there at Value Options, he suggested a radical reorganization along product lines, which is accepted by the owner and CEO. Dr. Greenwood was made president of the health plan division, where he tripled revenue in just 2 years. Hopefully you can tell us more about that. And I'm not sure that's on the agenda, but and then in 2004 he was recruited by Anthem Blue Cross Blue Shield to internalize our behavioral health services in the East and Central United States. This was the combined membership of over 20 million lives. Let's see. And then in 2008, moved to San Diego, started 2 companies, Human Capital Specialists, a healthcare consulting company, and Home for the Holidays, a nonprofit organization that provides financial awards to active duty military families so they can travel and be with loved ones. The first contract for Human Capital Specialists was with the largest nonprofit insurer in the U.S. The consulting involved evaluated how behavioral health care was managed for 13 million members and recommended a variety of possible options. The engagement lasted, the insurer selected the option to internalize and integrate behavioral health care, and this was a 2-year project which was deemed a genuine success. And then we have Sabra Matovsky, the Director of Contracting for Molina Healthcare San Diego, and she has spent the past 17 years of her career focusing on the healthcare challenges of San Diego's low-income residents, with a particular emphasis on the role played by the community mental health centers. She sits on a number of community advisory boards, including San Diegans for Healthcare Coverage, the Consumer Center for Health, Education, and Advocacy, the Coordinated Care Initiative, and Healthy San Diego's Consumer and Professional Advisory Committee. She has an undergraduate double major in economics and psychology from Oberlin College and an MBA from San Diego State's executive program. And lastly, a newcomer to the panel who,
The mystery guest.
yeah, the mystery guest, and you can guess what his background is, because his name is Steve Blake, and he's graciously accepted the invitation to join us at the 11th hour here, and he's from HealthNet. Thank you, Steve, and thanks to all of our panelists.
Okay, thank you, and especially thank you, Steve. I put him on the block a little bit just because we wanted to bring in HealthNet as a great partner.
No, 5 minutes is fine.
Okay.
That's all the minutes notice I need.
And I've certainly had my time up here in front of you fine people, so I won't spend too much time. Today we want to talk a little bit about, earlier I spoke about, bringing everything together and being great partners and collaborative models and all that kind of stuff, which we certainly are in San Diego, but, there's also challenges, and I think you guys will find these challenges in different counties, of working with multiple health plans. And, in San Diego, it's really cool. We've got 5 health plans, 4 for CalMedi Connect and stuff, and we try to do everything one way, but we'll try to make decisions in San Diego, and some of my plan partners, have to struggle with that because they have these corporate bigger people that they have to get buy off on, and it creates challenges. And so we wanted to focus and go plan by plan a little bit and chat about that. So just briefly, the company I actually work for Community Health Group, we don't face those challenges as much because we're the only San Diego only Medi-Cal managed care plan. We don't have members in Riverside or San Bernardino or anybody else. We are licensed strictly for San Diego County. And myself, I go back a long way, but my health plan started in 1982 in Medi-Cal Managed Care. So we've been around for a long time. And we started underneath a parent company, which is San Ysidro Health Center, a federally qualified health center. And so the health center, at one point, leadership decided, let's get into this new Medi-Cal managed care business, and Community Health Group was born. And part of San Ysidro Health Center was a huge behavioral health division called Behavioral Health Group. And at the time, they were our San Diego County's largest organizational provider system. We had 13 different programs, and I actually worked for Behavioral Health Group. So I came from that county organizational world. So when it comes to our collaborative models and everything we do and getting to know the systems, it's been really easy for me because I know our county mental health system very, very well, and it goes back a lot of years. But working with our partners and certainly chairing our behavioral health work group, there's been some challenges, like I talked about earlier, with Kaiser being new to actually treating these Medi-Cal members and the differences and stuff. So I think I haven't had as many challenges, but that's enough for Community Health Group and myself. I'm going to turn it over to our next speaker, which you. It's all yours. Any questions later, maybe?
Yeah, so I'm just going to sit here. We're going to hopefully leave some room for discussion later and questions. So as we mentioned earlier, my background is also in social work as well as business, and I hope to utilize that in my role here for a behavioral health program at Care First. So a little bit about Care First Health Plan. We are primarily for those that are underserved. We have a small niche in LA and in San Diego. We're expanding into other parts of the nation. We have some business out in Medicare with Arizona, and just this year we started out in Texas. So our organization started with Medi-Cal. That's where our passion was, and that's where the majority of our membership lives. You can see here we have up to 78% of our membership that we manage is in the Medi-Cal population. So we're very intimate in making sure that those members are served well. And we take a lot of consideration into how the members are accessing care. So a lot of our staff support. We recently added a social services department specifically to assist with those additional services that have been added under Medi-Cal. So one of the things, as we know, Medi-Cal expanded its mental health benefit to include mental health services on more of a less severe model for all of Medi-Cal members. And in doing so, the organization had to consider, well, now that we're responsible, how are we going to move forward, make sure that they get care that they need? So they thought about the amount of time that they had to prepare and what to do with that. And so what they did was they chose to use an MBHO model for both counties, so for LA and for San Diego. And myself and Dr. Greenwood would talk a little bit about what the differences are for each county, because it is very geographic in the challenges and solutions that had to come out of that. But to help manage that, what we appreciated is that there's on-site staff. We felt it very valuable to have on-site staff for behavioral health services to coordinate care with our members on our physical side and make sure that that was available. The other piece of that was we got hired. So, they chose us for our clinical background and our awareness of the MBHO world and what that meant for Care First. So another piece, just to expand upon that, so as the Care Coordination Initiative came out, it was recognized that we needed to find opportunities and seize those opportunities to collaborate more than your average, you guys do behavioral health, we do physical. So we incorporated our physical side and our behavioral health side into what we're calling rounds. They're not just a standard 15-minute call on 100 patients. It actually lasts a bit longer and is very detailed. And so we ask questions about the physical health, we ask questions about the mental health, and we try to figure out, where are opportunities to get those members the services that they need. Out of that also, I think, is a bit of education on both sides, making sure that both sides are aware of these needs and how we can access the benefit. So it's educating how they can access the benefit. And so what we've appreciated is the knowledge of both sides and coming together and making sure that that is attached. So the integration of behavioral health. So although Care First has chosen to use an MBHO model, they are a separate organization, but we needed to find a way for them to come and be integrated with us. And how to do that was really focusing on 3 key areas that would also connect our providers. And that was care management, integration of county providers, and PCP support. And there's some details for you to look at, and I believe this will be available on the website as well. But these were the 3 key areas that we wanted to focus in on so that both of the providers and our staff were really connected in different levels. So for the care management activities, that's kind of where a lot of the rounds came out of, was to make sure that we had opportunities to connect on the care management level. And then the integration of county providers, that has been a wonderful opportunity because San Diego has taken an approach, connecting with the mental health at San Diego at a different level, as well as LA. And so both building those relationships, understanding the providers that are available, participating in those trainings and educations, and really developing those collaborations. And then we have the PCP support. So a lot of our membership understanding where they access care and how they get introduced to other forms of care, really we needed to connect with the PCPs and make sure that they were aware of this benefit and how they could help the members get access. So reaching out to them too, and making sure that they're aware of that. All right, Dr. Greenwood, here you go.
Yeah, I just want to say that I joined Care First in November of 2013. At the time, I wasn't aware of what I was getting myself into. I've had a lot of, really different jobs and everything. And when I joined Care First, I felt absolutely overwhelmed with all of the challenges and all the new stuff to learn and everything. George was very supportive of, helping me get up to speed. But I felt really comfortable on the day that the county clinical director, medical director, if you would, made the comment that it felt like we were trying to build a plane while in flight. And that was the experience I was experiencing, so it felt good to know that somebody else was experiencing the same type of thing in terms of the challenges, that and all the materials that were coming our way. I want to talk briefly about the challenges and then some of the solutions that Care First, had to deal with as we worked with two different MBHOs, one in San Diego and then a different one in LA County. And the first challenge was network adequacy. That's what prompted us to go with MBHOs who already had networks in place as opposed to our developing our own network. It was a matter of expediency in terms of just having a network. We'd never have been able to build the networks in time for the 1/1 start date. Network accessibility was also an issue, and again, the MBHOs helped in terms of having connections in rural areas, but they also both are active in telemental health and are able to provide services. Just a point of note for anybody that does telemental health, because I've been on a national organization, Skype is not a secure video approach. So if you're using Skype, stop, because you are violating the law.
Your free tip for the night.
Free tip. Other challenges that we faced were just the placement of dually diagnosed individuals. Are they medical? Are they behavioral health? Are they both? Who takes the lead? We've worked out a system with the MBHOs where we identify who's prime, whether it is behavioral health or whether it is physical health. But we have many members who, of course, are dually diagnosed. And this system has allowed us to make sure that nobody falls through the cracks, that it's clear who's responsible for the development of the individual care plan with input from the other. If it's behavioral health prime, the MBHO is responsible to develop the care plan with input from the medical side and vice versa. Another challenge, as was discussed briefly earlier, was just provider participation in education. There's a lot of information that was disseminated to a lot of different people. They interpreted differently, got a lot of calls asking about things that may not even have been resolved at that point in time. George did a wonderful job of through our Healthy San Diego Behavioral Health Work Group with setting up presentations to providers throughout the San Diego County. I don't know how many providers total have been presented to, but I know it's close to a couple thousand. So that was very helpful. We provided education and were able to answer questions in person and did get a lot, some of which we couldn't answer at the time because we didn't know the answers. Another challenge, continuity of care. As you all know, with the, I'm blocking on the initial group that came on board, George, SPDs. The continuity of care, very important. Under Medi-Cal, they can stay with a provider for a year. If they've seen, if it's PCP, them once in the prior 12 months, and if they've seen a specialist twice in the prior 12 months, they have the right to continue with that provider, provided that 3 criteria are met, and I won't go through those. Another challenge was the FQHCs, because we really knew that they were treating a lot of the members that were a part of Medi-Cal and the expansion, and that the CMC, Cal MediConnect, And so we had decided very early on that we were going to contract with all of the FQHCs. And that was done through our MBHO, and we were successful in doing that. We also contracted with the county agencies because we felt that they also were seeing a large number of people that were our members and wanted to make continuity of care as small or minimal of an issue as possible by having those individuals who are being seen in these different entities, have the entities be a part of our network. I'm going to skip over a couple just in the sake of time that George talked about earlier. Another major challenge for us, and I think it's still a challenge, is the understanding the new benefits had for multiple stakeholders. Variety of stakeholders that are involved, from the members to the health plans to the county to the state, and oftentimes people had very different interpretations of what was supposed to happen, or interpreted information that had been disseminated differently and everything. And again, that was one of the reasons that we put a lot of time and effort into meeting with and educating primarily providers. George went over the severity tool, the one page, this morning, and we actually distributed that to all the FQHCs so they could submit claims based upon severity, and that has worked out very well. But again, the multiple stakeholders, there's a lot of communication that has to be done. And so, for example, with the continuity of care, if you identified the individuals that were receiving care, you could send notices just to them. We chose to send notices to all of our members because the data that we had gotten ended in terms of claims paid through September of 2013. And if you think about the claims lag and then the new people that came into the system October and on, then they wouldn't necessarily be captured by the data and everything. So we made sure that we sent out notices to all of the members, not just those required through the mandated requirements. I think everybody would agree that a big challenge, and I would have added, had these slides not been turned in earlier, I would have added autistic spectrum disorder to this in terms of short implementation timelines. I don't know that I've ever experienced one with a shorter time frame. But even the expansion and then the CalMeta Connect, the timeframes to get ready to oversee 2 MBHOs, it really was a rush to get everything done, and there are still things that are being worked on, and that's not unique to us. With the 2 MBHOs, another challenge for us was we had to oversee the 2 MBHOs to NCQA standards. And there's a lot to that if you've ever worked with an MBHO and you have to do oversight, because we have delegated claims, quality management, quality improvement, and credentialing to them. So we have to oversee that, and we've set up a very effective system for tracking all of that and making sure we've audited both of them, and we'll be doing that was a pre-delegation audit, but we'll be auditing them also on an annual basis as required. And then the member service department preparedness. We had to do training with, of course, our own member services in terms of, the questions that they would be getting, where to go to internal for answers, such as myself or Catrina for behavioral health. And so, again, the coordination with 2 MBHOs added a additional challenge just communicating everything to both of them, and it seems that neither of them did things the same way. So that was a really challenge. And at the time, Catrina hadn't come on board yet, and I made the comment to the chief medical officer that the job I was hired into was not a one-person job, and he was very receptive to that after having seen what all needed to be done. And Catrina came on board and has been a real asset. Jumping now to solutions that a few of them that we've implemented. As I said, we're using the MBHOs to reduce the time for the network development, the contracting, that's all in place. Oh, I'm sorry. Yeah. Thank you. And that has gone very well. Very large networks were covered completely from a geo-access standpoint. A lot of different specialty providers, and as I said, telemental health as well, which I think you're going to see increasing use of. As you know, it was initially started by the Department of Defense, and they've used it very extensively now, both in Iraq and Afghanistan. We did have the MBHOs submit to us training programs for the providers, because we wanted to make sure that the information that they were imparting to them was in fact accurate, but we wanted to make sure that their providers, because it is their network, it's not our network, were informed and aware of all the rules and regulations and requirements. And they also had to contract brand new with the FQHCs and the county agencies, which meant also negotiating rates for them. We next addressed the issue of integration that Catrina touched on briefly, and wanted both MBHOs to have staff on site at our San Diego office and at our Monterey Park office. Initially there was some resistance to that, but we were very adamant. And there was a comment made yesterday that it's not about being in the same place, it's more about communication. I couldn't agree with that more, but I really, after having done integration now since the mid-90s, it is really a benefit to have both the behavioral health and the physical health people located in the same place. They can talk with one another on an informal basis. They can consult with one another immediately rather than waiting to the weekly rounds that we do have, and you know, we use that time primarily for inpatient cases. But having people on site really does make a difference in terms of how effective the communication is. And I'm a true believer that the informal communication that takes place, the physical health staff just learning behavioral health from having behavioral health people on location, and vice versa, has been a real asset. And so I'm a real supporter of requiring co-location. As I said, we participated in community and training of providers, as well as just educating the community. We worked collaboratively with Healthy San Diego to develop training and communication to providers so that they wouldn't be receiving different communications from the 5 different health plans. We also did a unique thing in that in terms of the county providers who were not used to being credentialed or whatever, because they did need to be credentialed to be a part of the network and everything. This was before I came on board, so I think it was Sabra and George and others that talked about it, and we actually hired a single CVO for all 4 health plans that were contracting, and thus we didn't overwhelm the providers in the county with having to fill out 4 separate applications and everything, and the 4 health plans split the cost. The county was very pleased with that, and they really facilitated it by, you know, identifying an individual at each agency that we would work with, actually the CVO that we hired to do the work. And as a result, we got very good results. We got timely contracting, and the credentialing was taken care of. Of course, it had to go before the credentialing committee of each of the individual health plans to give the final stamp of approval. But that was certainly something that was unique and saved, I think, the providers a lot of time. And we just felt that it was a good thing to do. We always approach things also from a do not reinvent the wheel. If there's something out there, the health plans shared, you know, forms and stuff with one another at the Healthy San Diego meetings, and then we decided that we would, you know, have a standardized approach to many things. And again, George mentioned this morning that the coordination of care document is used as the standardized form for submitting so that we all get the same information on the same form. I did want to mention that Care First also opened primary care clinics in northern LA County to fill a need that we felt was not readily available. Now, these clinics have been around for some time. And the last thing I want to talk about is just briefly, we did collaborate very closely with a lot of the service organizations. We've had numerous meetings with the regional centers. That's been particularly helpful in light of the fact of the autism spectrum disorders coming on board Monday. I will say that Care First and a number of other health plans do not have networks in place for that at this point. We're actually in the process right now of negotiating from proposals that the 2 MBHOs have provided us to decide what's the best approach for us. And I'll stop there and turn it over to Sabra.
Okay. So we actually sat in order here. I'm not sure if I can, George, I'm not sure if I can reach the clicker from here. Can you click for me?
I'll click for you.
Okay, thank you.
The things our health plans do for each other.
No kidding, I owe him one.
Okay.
So
I
we
can't go
did
back.
actually sit in order today to try and give you a perspective from a health plan that operates exclusively in San Diego to one that has a little bit larger reach, and we're moving down the table toward the larger plans because some of the challenges that we face and how we address them differ a little bit based on the size of the health plan and some of the other considerations about what we may be doing on other fronts across the country or other initiatives that the health plan might have underway. So, yeah, go ahead. So just a little bit of background on Molina so that you can see the difference in size between all of us. Founded in 1980 with a single clinic, we operate both community clinics that serve the Medi-Cal population. We've expanded those across the country in a number of the states that we operate in. We are NCQA accredited. Molina has now expanded from that one clinic formed in 1980 by an emergency room physician who saw that his patients didn't have anywhere to go once they were seen in the ER for follow-up for primary care, into a Fortune 500 company in 16 states. So next slide. We touch more than 2.25 million Medicaid members across the country. We operate health plans in a number of states, and then we also serve as a MSO or a claims payment option for states who need someone to pay for their Medicaid services. So we are both a health plan and we are also an administrator of Medicaid services, and we also provide direct care through clinics. A little bit of a, I'm not sure if it's going to click it one more time and see, I had a little breakdown of our population. Looks pretty similar to most of the other health plans. 81% the TANF population, the moms and kids, more of the welfare population, small footprint in Medicare right now, but definitely expanding, and then an increasing part of our pie is that aged, blind, and disabled population, which is at 13%. Okay, go ahead. I don't think, just fill it in. Yeah, you can do the whole thing. So in terms of things that we specialize in, we really started in the Medicaid space and have expanded into Medicare with the special needs programs and the CalMedi Connect program. We do have a small footprint in covered California, and really the strategic thought there was that there are a lot of patients and people that we take care of who fluctuate above and below that line that separates you from Medi-Cal to getting your insurance through the exchange is not a line that most people have in their heads on a regular basis. And when your income is tripping above and below that line, you're coming in and off a Medicaid plan and onto covered California. We wanted to exist on both sides, for our patients that may have variable income. So that's kind of a new front for us. It's a little bit different for us in that we're not really a commercial plan. We're doing it more as an expansion to serve some of our members, but we don't see ourselves necessarily as a traditional commercial plan. Go ahead on the next one. Not going to spend a huge amount of time on the healthcare trends. I think that's been covered pretty well in terms of the Affordable Care Act, new benefits, more managed care, more managed care, more managed care. I don't need to say anything more about that. So next slide, in terms of considerations. So, what does that mean for Molina? You saw the slide, we're pretty big. What kinds of decisions do we cycle through on a regular basis? There are always opportunities in different states as contracts come up to bid to potentially be a Medicaid plan or to provide those third-party administrator services to different states throughout the country. So that's always on the radar screen. We operate in 6 counties in California, but those contracts also come up to bid, and more of the different counties who may not have been as focused on managed care are moving more toward a managed care solution. And so, that's another consideration in terms of where we want to be in terms of different states and different counties. Also new product lines. So we are in the Medicaid space now in Imperial County. That was new within the past year. We will be in Medicare in Imperial County effective 2015. We didn't decide to expand our covered California product yet into Imperial County, but those are the kinds of considerations that we go through if we're not in all 3 of the different product lines that we operate in, the Medicaid, the Medicare, and covered California. Are there different markets where we want to expand our lines of business that we work in? And those different contracts come up, those networks need to be contracted and filed within certain periods of time. And given all of the other opportunities that are in front of us, it's really a question of strategically where do you want to expend your resources, because there's just so much growth going on right now that trying to be strategic in what you decide to take on so that you can do it successfully is really something you have to consider as a plan. The other piece, either through planned expansion where the health plan's had a decent amount of notice about new benefits coming into the existing products, or something that happens relatively quickly where we don't even really know the rules of what we're supposed to be providing until after we're providing them, the flying the plane and building it kind of concept. But being ready for new benefits, and then what do you do with those new benefits? Do you contract it out? A few years ago, we had a similar solution to Care First where we did contract out our behavioral health services, and we went to a one-stop option in San Diego where we had a single company that did our utilization management and contracted the behavioral health network, and we saw that as a good solution at the time. But we changed that as we started looking at where the business was going and where mental health was going and how that was going to become more and more a focus and of what we were doing, and call for the kind of integration that we felt was coming. It seemed to make more sense for us to build our own behavioral health network with community providers, but we would do the utilization management. We would have the employees that would do the case management for our behavioral health patients and work with the county, work with the providers in the community, work with the FQHC. So we did switch up that model. So next slide. So in terms of, how do we make some of these decisions? Do we want to create it ourselves? What is the long-term projection for these services? Is this something that will become increasingly integrated, where the expectation is that the health plans will take on more and more of this responsibility in future years? If that's one of the considerations, then it's probably important that we develop some of those core competencies within the health plan. So that would be something, as we're looking strategically at moving forward, that would go through the health plan's mind. In developing that internal expertise, we're in Cal-Mediconnect County. We're in several in California, but there are 4 states that are involved in similar demonstration programs that Molina also operates in. So, and then you look at what may happen nationally as these programs gather more steam. Is this something that we're going to need to know how to do? And is California going to be one of the pilot counties for Molina to really come up with models, systems, and processes that we can use elsewhere within our organization? So it starts to make sense for us to go through the pain, really, of creating those direct systems within the company and figuring out where to put the staff and do all the training. So, those are definitely things that we think about, as we're looking at some of these opportunities. The clinical integration, with us having behavioral health social workers and our medical social workers side by side, working together with our interdisciplinary care teams, with any kind of emergency conferencing related to members, it gives us that extra high touch and ability to respond quickly to any burgeoning situation that we may need to face. We've also hired community connectors, where we have staff on site that will go out and find members that we need to find that have been difficult to contact. They may go to the pharmacy. If they're picking up medication regularly, do they have a different phone number or address for that person? Go to their last place of residence that we had, talk to the neighbors, check in with family. Do they know where to find this person? And so they can bring that information back, not only to the clinical folks on staff, but also the behavioral health, and they can conference about solutions for particular members. But all of those folks are Molina employees, and they're housed in the same office, so we can have that kind of model, that team approach to trying to solve some of the more difficult problems that we face. Again, because we are larger, some of those economies of scale, if we can get the model down right and we can get the right staff, the right training, the right documents, and what we develop in San Diego lots of times will carry through to what we're doing in the Inland Empire with Riverside and San Bernardino, what we do in Imperial, what we might do in Sacramento, our Los Angeles approach. You start having, when you build some of these different tools, you have the ability to export them and tailor them and tweak them a little bit to other markets. So it starts to give us a little bit of a jump start in what we're developing. I've had a terrible problem with office space, honestly. As soon as we expand, we're full. So we moved into new space less than a year ago, and I think we have 1 cubicle open, and we're going to need more. So just trying to keep all the staff. So that's definitely one of the challenges when you're doing one of these in-house models, is where do you put everyone? But we're working our way through that. Another piece that's been a challenge in terms of a build model where we're putting it together ourselves is the cultural competencies to serve our populations. In San Diego, we're the 2nd largest resettlement area for the Chaldean population, and trying to find not just behavioral health, but the physical health, all the things that you have to deal with when you're dealing with different ethnic populations that are really concentrated maybe in a couple of places in the country. I think Detroit is the other major Chaldean area, but trying to find, the appropriate resources for those types of populations. And sometimes there are significant waves of immigrants coming in large amounts that really make all the other challenges that I've talked about just exponentially harder when you're dealing with language and cultural issues that are kind of very isolated in certain parts of the country. But that's something else that we deal with all the time. So one last slide. So I've touched on these a little bit, but some of the things we're trying to do is the staffing and the training. A lot of what we get for preliminary rules, you want to go out and train everyone so they're ready the day that a program launches, but unfortunately, those rules are preliminary, and by the time they go to final, they may be different. And so we hear from the provider community all the time. We also hear from our staff, you know, is the training ready? We want to be trained. And if you train too soon, you're likely to give someone misinformation because those rules change. And so when do you train, and how frequently do you go back and correct any discrepancies, or, you know, take something to final, which may not really be final because there'll be a revision in 2 weeks. So, you know, that part is hard. With our staff being internal, though, we feel like, at least in terms of being able to handle some of the nuances in training and the changes, that we're a little bit more on top of it because they're employees and we can get that information out relatively quickly. With us being that big and trying to develop economies of scale, you want to make sure that you don't lose those local nuances. San Diego's a very unique community. There's a lot of working together to make things simpler for the provider community and to build those partnerships. And so balancing the national objectives of uniformity and economies of scale with also appreciating those local nuances is just another factor that you have to work into the mix somehow to make sure that you've really got a program that'll be successful in whatever county you're operating in. Some of the other things that we've had to deal with is the actual implementation of some of these programs. So I just took, for example, the differentiating between the mild to moderate and severe. George shared the tool that we developed that helped us, not only the quick reference guide that was really for non-clinical staff, but also the more in-depth tool and trying to be able to parse those different types of populations apart so that we could figure out who was responsible. But then how do you operationalize that? If it's not a diagnosis-driven issue, then someone could be schizophrenic, they could be mild to moderate, they could be severe. How do you know that coming in? We've all struggled with what to do with authorizing those services. You know, if you authorize it and you actually look at the clinical notes coming in, you may have a better idea of differentiating the mild to moderate versus the severe. But from a provider perspective, sometimes that's perceived as a barrier. You know, why do I have to get authorization? I may with this health plan, but I may not with this one. You know, why? I don't understand that. Well, if it's not diagnosis driven, where this diagnosis is definitely going over here and this diagnosis is going over here, then it would suggest that there needs to be some sort of review by the health plan to decide that this is a health plan responsibility versus a county. So I think we've all struggled with trying to not put any unnecessary barriers in place, but the way some of these programs have rolled out, it has not been as obvious or clearly defined for us so that we can tell what to do with some of this care. It really takes a deeper level of looking to determine who's responsible. And then the other piece that I think we tried really hard collectively was to, at least if we were wrong, let's all be wrong together. In terms of getting information out, you know, whatever regs we were working on, whatever, you know, we understood to be the rules at the time, that we were all saying the same thing, and maybe
There's
we
safety
all,
in numbers.
Exactly, maybe we weren't right, but at least we were all trying to say the same thing, because it's probably worse for us to all be all over the board. And so it's pretty common that we have a lot of conversations with, okay, what are you doing on this one? You know, how did you read this reg? You know, so that at least we're not putting out even more confusing information by having everybody say something different. So those are some of the things that we've just been trying to do. But just want to give you an idea from a health plan perspective, you know, how some of these things roll through the organization and how we try and address them.
And let me, since I forgot earlier, you know, Sabra talked about our screening tools and stuff like that. The first one we did was that simple one, and then we got more into the details of the more severity ones that licensed clinicians would use, and I want to give some credit to our county clinical directors, which is Dr. Krelstein oversees the adult stuff, and the whole system, and did our adult tool. And Laura, sitting up, you got to wave, is our psychiatrist that oversees children's services, did the child adolescent severity tool on behalf of our Healthy San Diego Behavioral Work Group. So if anybody has any questions about that tool and its development, just bombard her later.
I'll teach her.
Great, thanks, George. So as I was introduced, I'm Steve Blake. I think it's a testament to George's organizational skills and recruitment skills and bribery skills that about 12 minutes before the start of this presentation, I was going to be an attendee, and now I'm on the panel itself. So,
I said, no, you're not.
and then a testament to what a smart aleck he is, when I got up to the table here, he came over to me and he said, Steve, when you're presenting, you really should wear a tie.
And I forgot I didn't have one on.
And I obviously have no slides, so I'm going to get George back by asking him, so you don't have to just listen to me talk. I'm going to ask him to do a modern dance interpretation of my comments while I'm talking.
I can. I'm a former ice skater, just so you know.
Okay, so again, my name is Steve Blake. I'm the Vice President of Clinical Services for MHN, which is the behavioral health subsidiary for HealthNet. And I thought I'd talk a little bit about HealthNet to start, my role there, and some of the different things that we're doing, and then kind of bring it in for a landing, talking about what we're doing in some of the specific counties and for Medi-Cal in California. I've been with MHN for a little over 16 years now, and prior to that, my background was in direct services. I ran child and adolescent and adult inpatient psych units, and LCSW by training. The HealthNet health plan has gone through a lot of evolution in the last several years. We have traditionally been a national health plan, and several years ago we divested of all of our Eastern region business and really have become a Western region, Arizona, California, Oregon, Washington health plan. And that's true for the commercial side. We also have some different government-directed businesses, and that's where a lot of the evolution has been. We have, HealthNet has the management of the largest TRICARE contract in the country, working with military retirees and families in the Northeast. In addition to that, we do Medicaid, Medi-Cal programs in the states where we do commercial work. We do Medicare work in all of the states where we're doing commercial work. And then MHN, in addition to providing the behavioral health management for all of the commercial membership and the Medicare membership that HealthNet works with, we also do a small amount of retail, commercial, carve-out managed care, although that's in this era of coordination, integration of medical and behavioral. That model is sort of a little bit trickier to work. We also have about 2 million eligible employees for our EAP services nationwide, so about 4.5 million members. And our commercial membership in the Western region is several million members. We also have about 1.2 million Medi-Cal members in California. And so we're doing a number of different things that we refer to as government directed, and it's always been a little bit interesting to know where that kind of falls and who's running that part of it. For example, in Medi-Cal, because the behavioral health portion was traditionally carved out entirely from the Medi-Cal managed care plans, MHN really has had no role with the state health program, which is really a missed opportunity. Now we can see that in hindsight, that even though we weren't managing an actual benefit, we really could have engaged years ago in coordinating medical and behavioral with the county. In the bidding process for the Cal MediConnect, we were awarded both the San Diego contract, or as one of the plans for the San Diego contract and one of the plans for the LA County contract. And so we are in the position of implementing it in several different counties, which on the one hand is nice because you can learn from what they're doing in both counties, but on the other hand, it can be a bit of a challenge because you're trying to do something as efficiently as possible and trying to drive to standardized solutions that two different counties may be doing things in two very different ways. And so it's really been nice to engage with Healthy San Diego and this group on really being on the cutting edge of designing some of the assessment tools and some of the workflow tools. That's been really helpful in our work across the state. You know, one of the things that one of my coworkers asked me to talk a little bit about was, it's been mentioned, this idea of building the airplane while it's flying, and that's absolutely the truth. And I think one of the things that I know I fall into and our organization falls into, and I think that we all do, is that even though it's a pilot, even though it's something that we're looking at over the course of a number of years, even though different states are experimenting with something different and different counties in California are experimenting with something different, we all want to be good at what we do, and we all want to be right. And So we start to think in terms of, okay, we've got to design a plan and we've got to implement something that is the right thing on day one. And when we take a step back, we understand that that's certainly not going to be the case. And sometimes it has the effect of kind of closing our minds off to this idea that we're learning here. And some of the things that we implement today or have already implemented, it's okay to abandon that in 6 months or a year if it turns out this is not working, or if it turns out, hey, somebody in another county or somebody at another health plan has a better idea. And let's beg, borrow, steal those things and really roll those out. So continuing to focus this idea on being a learning industry, being learning organizations, and not being able to make those mid-course corrections. I think the other thing that we have sort of struggled with and learned from in this process has been the CalMedi Connect implementation at the same time as the Medi-Cal 133 behavioral health expansion. And we're doing the CalMedi Connect in just the 2 counties, but we have our 1.2 million Medi-Cal members are in 10 counties. So we had already gone down this road of the last couple of years of really being engaged with LA County and with San Diego County. And so that this new population that we're working with, we had these existing relationships that we were able to leverage in talking about, okay, how are we going to make some of these distinctions about the level of impairment? What is going to be the workflow? And it really was an example of how those existing relationships, we could leverage it for a new product and in a new way. And by comparison, the counties that we weren't doing CalMedi Connect for the last several years in, all of a sudden we're now needing to reach out and connect with those counties, and not having those existing relationships, it's much more of a building process. And so for those of you who aren't in one of those 2 counties, your relationship to the health plans who are doing the Medi-Cal carve-out business, we're kind of building it as we go there as well. Certainly those of you who've been working the last couple of weeks on the ABA for Medi-Cal rollout, that's been a real challenge across the state. And I was going to tell George, he was wondering if they had had any calls yet. We actually got our first call while you were talking this morning. So we've had exactly 1 ABA call for Medi-Cal so far.
And I had one at lunchtime.
Yeah.
At my first.
The other thing that I would say about the HealthNet model, and it's a source of great challenge, but a source of great opportunity too, is that we use, by and large in California, a delegated group model so that we don't manage and contract with individual practitioners and pay fee for service. We capitate the management of the medical benefit to IPAs and medical groups in California. The advantages are oftentimes those medical groups are geographically circumscribed. They're parts of the community. They understand the specific needs of that individual community in a way that a larger health plan never could. But it also means that when we're coordinating care, we're needing to coordinate behavioral and medical care, not just with sort of one entity, but many different entities, all of whom have different electronic health records, different processes, different approaches. It's also nice to have these different laboratories where some people can experiment with, hey, we're going to put mental health practitioners in our clinics with our docs, or we're going to place mental health practitioners in the emergency room, or have a process for behavioral health practitioners in the emergency room in the region where we're working. And so we're going to, again, be learning from those different approaches to say, hey, this is working in this group. Let's see if we can propagate that out to the other groups. Obviously, 2 of the biggest challenges that we continue to work on, first is technology, this idea of a shared care plan, and not just a static care plan, but a shared communication approach. Certainly people can call one another, people can send carefully encrypted email to one another, but oftentimes that just doesn't happen. And so how can we leverage technology to really make the information available across the system of care? So we are piloting a product called Apollo that the Alir makes, and it's a portal where the health plan, the medical groups, county mental health system members can all access based on the amount of information that they need or are eligible to access can go and have a single location. It's got a lot of exciting possibilities, but we also recognize the limitation because, again, it's anchored in one health plan. So as people are moving through, so I think the ongoing conversation about what is going to be the technological solution that even if we don't all use the exact same one, even our solutions will need to be able to talk to one another. And I think that's going to be one of the real challenges. Obviously with that, I know folks have mentioned it already, continuing to work through the challenges of the consent requirements where we're trying to share and integrate this behavioral health and medical information and wanting to, on the one hand, attend to people's very real concerns about the confidentiality of this information and to be careful with it. And, you know, we hear another story every day about this data set getting hacked and people getting access to this data set, and people are very concerned about that. But at the same time, I think we have not only a clinical duty, but a fiduciary duty to really be identifying those cases where somebody with a behavioral health condition and a medical condition, there's something actionable that we can do that's actually going to improve the quality of the care. If we're not doing that, then we're falling down on our jobs. Let's see. That's sort of the stuff that I have. I think I'll wrap it up here, and I'd be happy to address other questions that people have or make additional comments in a question and answer period. So thank you very much.
Any questions?
Yeah, thank you very much. I don't think we have a microphone, so please. Yeah, all right.
Yeah, I once had a psychiatrist who worked for me, and he said I was very concrete, and not knowing scientific terms, I thought it was a compliment. So I'm going to be concrete and talk about the elephant in the room. The three most important things in terms of integration of health and behavioral health care really are listed in order are reimbursement rates, reimbursement rates, and reimbursement rates. And we don't seem to be talking about that. When health plans contact us and say, oh, we would like, we're now in charge of the less than non-carved out Medi-Cal population, and we'd like to contract with you for $57 an hour when our costs are, $125 or north of that an hour. It's really a non-starter. And so when I hear that a health plan, that it was in the introduction, they were able to triple their revenues or something like that in the introduction, we feel as providers, it's on our backs that that's being done. And so I want somebody to talk about we're a very nimble group. We provide a lot of services, a lot of quality services. I run a children's mental health agency that's been in business for 50 years, and we do excellent work, but we can't work for those rates. And so we just want to know, what's the discussion about paying a living wage, as they say, which is the term that people are using in terms of reimbursing us for services.
I'll start. I think we all have something to say about that, and I think there might have been some miscommunication on our part that nobody said that we've tripled our revenues. We've doubled or tripled our membership.
I think it was a company that Dr. Greenwood worked for.
Right, for a company like that, but in our Medi-Cal managed care world, all of our health plans really struggle just to stay above water, like all of you do. We are all in the same boat, and that's what we're trying to do here. And in our business, we're required by law to spend at least 85 cents on the dollar, just in general. That's a general rule for the health plans. Well, Medi-Cal managed care plans right now across the board in California typically spend 92 to, I think it's $1.10 on the dollar. So as far as, anybody that might think there's millions of dollars going into our bank accounts, in most cases, a lot of the health plans, the big guys, I'm one of those little San Diego only plan, so it's a little bit different. Our problems are just in San Diego. you know, but it's scary to us that so much cost goes into every single member because we're not like a HealthNet or somebody else that has this giant commercial population that can absorb some of this stuff. As far as reimbursement rates for behavioral health, you know, I can tell you, I have a little bit of different model at Community Health Group, which is you have an extremely selective group of behavioral health providers and pay them quite well. So I don't have a single provider that complains about the rates. I can't say what those rates are, but I don't have that. But it's working so closely with them that they help, they do such an incredible job of making sure our members get exactly the right and appropriate amount of care. And we just trust them to do that. We haven't denied a single claim since 1998. For like our healthy families and the population we provided services for. In our last, every year we do a behavioral health satisfaction survey to our behavioral health providers, and last year's the satisfaction rating came out to 99.8%. So that's a pretty high, you know, just to address that. It's not always what you might hear. It definitely isn't as far as the rate stuff. Yeah, I know, but I hear you and stuff, and I know, remember, I'm different than these guys. I can only talk San Diego, and I listen to my friends here when they talk about some of these challenges, and I'm like, okay, I'm the luckiest guy in this whole business because I only have our little town and our wonderful county behavioral health people. It's a whole different world, and I get that, but, you know, and I also know that there are a lot of places, like for my health plan, other than CalMedi Connect, where it's a requirement to work with the county, and luckily we have the best county behavioral health in the entire universe, I believe. But other than that, like for my Medi-Cal population and anything else we've done in the past, we've never contracted or even considered contracting with a county behavioral health provider because I wanted to make sure those providers had the space and freedom to take care of all that population, and there's less waiting lists and stuff like that. So I keep an entirely separate network. I do realize that there are a lot of counties where there's not a lot of mental health providers, and health plans are trying to reach out to their county mental health providers to help them take care of the mild to moderate. Right, I know, so it's a little different, but, you know, please keep in mind, the Medi-Cal dollars for you guys are like the Medi-Cal dollars for us. There's not a dime to spare, and there's nothing left in our pockets, and you know, I'm jealous of the health plans that have something to help cover the cost and all the money they're losing. I know at my health plan, we were spending well more than that, 85 cents, or even over $1 per member per month. Anybody else?
Yeah, just to clarify the comment about tripling the revenue, that's by getting new business, which our providers at the time really appreciated, because and you know, we were able to actually offer rate increases, because when you triple your revenue, you don't necessarily need to triple your administrative costs, and we were able to share that success with the providers. Having been in this business now for 30 years, I'm concerned about the reimbursement rate to behavioral health providers and, you know, areas related. It's always been an area that has not gotten its fair share of the dollar. If you look at historical costs for behavioral health as a percentage overall that a health plan is spent, and this is on the commercial side, it's 2 to 3%. Now, there's a lot of hidden behavioral health care costs that are, you know, being accrued in a PCP's office or something like that, that a lot of times health plans don't take into account. But, for example, the reimbursement rate for PhD level psychologists today is in general the exact same rate as it was in '85. And that's a long time to go without any kind of increase. Actually, most health plans have decreased their rates to behavioral health providers. So that's a real concern to me, because it has meant that there is a lack of providers in a number of areas because they can do something else. I can't guarantee you that I would, you know, become a clinical psychologist today if I was going to go into private practice, because the rates have not kept pace with, you know, inflation even. Again, when the rate today is the same as it was in '85, you have a problem getting providers.
Okay, I'm confused about that. Our
Well, you have to remember, we're being reimbursed by the state on a capitated rate.
If we're getting reimbursed for the
all.
services that are being added. It's not uncommon for these services to come out, and so we can take the SPD, the seniors and persons with disabilities population, for example. You know, we were asked to take on populations where we were told rates were actuarially sound, and to a health plan across the state, the medical costs were running 110% of the reimbursement that we got, and it takes years for the state sometimes to make us whole, and that's not uncommon. Lots of times these new benefits roll out, the mild to moderate benefits, we haven't gotten paid yet. So, you know, the expectation that we can put extra money on the street when right now we're floating. And for us, for the bigger health plans, maybe we're making a little bit of money in North Carolina or we're making some money in Florida. We can cost shift that to cover the reimbursement until the 3 to 4 years it takes for the state to make us whole. But that's definitely impacting some of the smaller plans. But the idea that there's more money that we can put out than what's already being paid is a little bit of a fallacy. So the expectation that we've got the ability to change rates, right now we're subsidizing the state on some of this stuff. So.
Okay, yeah, over there?
So I assume the bigger health plans, you've got services in many states. In California, we have the carve-out, so the counties handle the seriously mentally ill, which in your system would be the high-cost cases. If you provide services in other states, are there some states where you do the whole gamut? No.
No.
Okay.
Yeah, for Medicaid, at least in the states that we're in, it's either the same as California or very similar. So for us, and I can only speak for HealthNet and the geography that we're in right now, contracting for credentialing and paying claims for behavioral health services for Medi-Cal started for us in January of this year.
How about for Molina?
You know, I honestly don't know. I'm local to San Diego, and I sort of fit my way up into the overall Molina structure, but I don't operate in terms of developing contracting networks outside of San Diego, so I prefer not to misspeak. I honestly don't know.
Is that something you would want to do if the carve-out was somehow eliminated?
You know, it goes back to reimbursement, and you look at all of the opportunities that we have about expanding into another state or adding a different line of business. Do we want to be in the exchange in other places? There are only so many resources, and if it's another program where the funding is going to come 2 or 3 years down the road for a very expensive service, is that where you want it? Is that the basket you want to put your eggs in? And I wouldn't personally be making that decision, but I would imagine that the people above me, you know, have to weigh all of those things into account.
And you are, of course, for-profit.
We are.
So if the bottom line doesn't work out, at some point you can say,
I wouldn't say that's, I mean, we've lost money for years at different points in California. Molina is still run by the family of our founder, and the CEO and the chief medical officer are the sons. And so at different points, we've subsidized losses in California for a long time. So, I mean, can you do that indefinitely? No. You know, but it doesn't mean that, oh, we're not profitable this year or next year, we're not profitable in this particular market or that market. You know, we're taking them out of our portfolio. It doesn't really work that way.
And with the realities of public sector funding, I don't think any of the plans, even for-profit plans, are looking at it and saying, oh, let's get in there and see if we can squeeze dollars out of it, because they're just not there. But I think that there is an opportunity, and I'm not even sure what it would look like, to, like we were saying earlier, increase revenue, not by gouging, but just by having more membership. And I think, you know, what you said about the carve-out in California, would we be interested in? You know, we're a health plan. We're not a provider of services, and the provider of services at the county level have done it, are doing it, do a great job, and I don't think that would change. So the question might be, what value do we think we could add to that, or what value does a county or the state think that we could add to that? But I think right now, I think the reality is we have to be able to coordinate with multiple entities, whatever those are, whatever we control or don't control. And so our focus is entirely on how do we coordinate with the county mental health systems, how do we coordinate with the other plans, how do we coordinate with the medical side.
Is that the same with Molina? Or,
Yeah.
so you don't run your own hospital?
Right. Oh.
We have like a management agreement with a hospital in LA, but again, that's not my territory. But we do have direct clinics, and that's sort of a legacy of our founder who founded the first clinic. So definitely there's a desire within the organization to still have providers and direct input from the primary care providers at what they're facing and trying to deal with these same populations that we're asking other providers in the community to deal with. So, to a certain extent, it gives us another level of insight into what's going on. But no, I don't think there's a direct desire to do that. I think, also because it's a family-run organization, there are a lot of ties to different parts of the medical community, particularly in Los Angeles, that run very deep, that I don't have privy to all of them, but it's more than just a for-profit business. It's a family-run business, and they take those relationships and connections seriously. So sometimes they make those decisions.
Okay, two more. You can decide who goes first there on that table. Okay. Sure. Well,
So, no, my question is a follow-up to his. So, in your crystal ball, as you look at managed care, taking over behavioral health, or all of behavioral health being managed care specialty and mild to moderate, what do you see happening to county mental health down the road? Do they get absorbed, or their business gets absorbed, or you contract ultimately with county mental health? Where does the current system go as this whole healthcare reform evolves?
I'll start, and I think it's a great question, and I spoke about it a little bit earlier. I think that our county behavioral health program, certainly in San Diego, provide a service that, in my opinion, our private health plan providers cannot provide. And we would need you guys if mental health, especially mental health, was carved back in. Do I, as one person in San Diego, believe mental health is being carved back in? Absolutely. Yeah, I mean, just everything is moving into Medi-Cal managed care. The writing's on the wall. County provided services that we never thought would be a health plan responsibility, like in-home supportive services. Health plans cover things with licensed professionals that we credential and we make sure they're wonderful and develop relationships and stuff like that. And all of a sudden in San Diego County, we've got 23,000 who knows who working for us, because anybody can be an IHSS worker and we have to pay them for services. These are things that 2 years ago, 3 years ago, we would believe never would be in our health plans, and now they are starting to be. Same with the MSSP program and stuff like that. So, starting to bring things like mild to moderate back in the health plan and all these other services is sort of riding on the wall, so I believe it's going to happen. I believe strongly that, at least in San Diego County, we have a behavioral health department that provides services that are way beyond what we're able to do. I can brag all I want about paying my private network a good rate and their 99.8% satisfaction rating, but our county's, clientele that they serve, my network's not going to want to serve. So I will need them and they will need me, vice versa. And I think that was my whole message early on today, which is this is a good time to start forming good partnerships. And I'm happy that San Diego's already got it. It gives us a jump in the right direction. I think when somebody's talking about rates and stuff, the county pays organizational providers, I have no clue what. It's a different formula, and it's very different than the way we look at things. And what we look at as being a really good rate might not be a good rate for a county mental health program. So let's start talking about that stuff so we know how we're going to work that out down the road if mental health was completely put in the health plans, and make sure our wonderful county behavioral health programs were in a position to continue business as usual. I mean, my idea, and just mine, not necessarily my company's, is is that we would just automatically contract with our county behavioral health to oversee those services, and the dollars that come down from the state to the county would instead come to us and get passed right on through to them, and we would keep our wonderful services intact the way they are, only better integrate and coordinate the care.
I guess I would also add that for us, to say managed care, I don't think it's a single thing. I mean, there are for-profit managed care plans, there are not-for-profit, there are public sector managed care plans that are county-based. And from our perspective, it's really sort of dividing the activity rather than the entities. So there's people who provide services, there are people who pay for services, and then there's this kind of middle ground of managing or administrating. How do you ensure quality? How do you drive best practices? How do you make sure it's evidence-based? That people are kind of playing with lots of different models there. And so if you look at the county today, are they a payer? Are they a manager of care, or are they a provider of care? And in some ways, depending on the counties, they're sort of all three. And we definitely, we're not providers of care, but we're payers and managers of care or administrators of care. And those are the two things that we do. So, you know, could we do that in new and different areas? Sure. Would we want to go into those areas? I don't know. But we'll never be the provider of care. And I think to George's point, the people who are providing the care today are the experts, and why would we ever not avail of ourselves of that? I mean, when you look at the ABA mandate from several years ago, that was traditionally the purview of the regional centers and the school systems. And through, you know, the vagaries of kind of healthcare politics, it was, well, let's have the health plans do that. Well, we're still not we don't provide ABA services. We're just contracting with people who, many of whom used to do it for the schools or used to do it with the regional centers, and now they're just part of our ABA network. So, you know, I think anything's possible, but that's sort of the way that we view it.
So for me, that raises another question. So you've got two populations that healthcare plans manage. One is Medicaid, and the other is your commercial insurance. But we've learned in trying to contract with commercial companies, unlike our presenter this morning, for this afternoon, is, no, it's this morning. Anyway, that on the commercial side, that there's no understanding of some of the services that are available on the public side. So you wrap around, or therapeutic behavioral services, or in-home services, or bachelor's level providers, or, you know, it's too intensive, it's 2 sessions a week by a psychologist. And yet you have, on the commercial side, there are kids, we're a kids provider, who have the same difficulties, the same issues, the same diagnosis as the kids on the public side, but the commercial insurance world doesn't know what to do. So what happens is these kids go to the schools, they get an IEP, they get services some other way. Is the commercial world, not the Medicaid, but do you foresee your colleagues learning from what's happening on the public side as a way to save money in the long haul, avoid hospitalizations? Where do you see that going?
I can start. Yeah, so certainly having providers in the network that are able to actually provide the services that are required is something that we're very interested in. And if we ever move into a new area, again, ABA is a perfect example, we want to have providers that understand the needs of that particular population. And we don't believe that you can just take somebody who's good at one thing over here and just plug them in over here. We understand that different subsets of the population need different things. Forgot where I was going. Let me see if I can catch it real quick. No, somebody else go. I have the second half of that, and I'll find it, and I'll jump back in. So
Okay,
somebody
all
else
right,
can
I'll
go.
help you out.
I just want to make another comment about reimbursement. You know, the federal government plays a huge role in what reimbursement is. They set the rates for Medicare, and most health plans, you know, follow the Medicare rates. And so, and they are also the ones that established that 85% of the premium for large health plans, commercial, had to go for cost of care. For smaller health plans, it was 80%. It will go up to 85%. But the federal government has a lot to say about what the rates are at a local level if you stop and think about it.
I remember the second half too. I think the other thing, especially when you talk about switching payers, is a certain sort of menu of benefits has evolved on the commercial side, so that if you offer commercial health insurance, here's what's covered. And with other payers, public sector payers that might combine school funding and health, Medi-Cal funding, there may be services that somebody's getting today that it's all inclusive. So Medi-Cal or the schools are paying for all of this, and it gets moved over to the commercial side. It's going to end up looking like a commercial benefit. So we also need to be clear when we're talking about a service that this kid really needs, but it's not actually part of the benefit structure that was moved over. And that's sort of like George was saying, that's one of those conversations that needs to happen. So the things that aren't part of the commercial benefit, where are the dollars still to pay for that? They didn't come to us, or there wasn't a plan for them to come to us. Who's providing it, and how do we make those linkages? So I think that's the other half.
Okay, I think we've got time for maybe one more question. Oh, no, I was going to, so it's you.
And they're starting to figure out that, yeah, this child needs X service. But they admittedly say, and this is one of the bigger colleagues saying, we only have individual and group therapy, that's all you can bill us for, so just make up some dummy rate. I mean, so where and how does that, we're going to recognize wraparound in-home services, and all of the services that are really in-home, they're intensive, they're keeping the kids out of the hospital. On some level, you guys are recognizing those services as the way to go and saving dollars. Where's that conversation taking place? I've heard other people from HealthNet say, behavioral health, it's just such a small piece. I don't know if we're ever really going to get to that conversation. We'll just kind of wing it with the individual and group therapy, and so be it. I don't know if that was, did you get the question?
Yeah. Right now it tends to take place over individual cases. So a lot of the things that you're talking about, the cases that you're talking about, start to push up on the area of closer to moderate rather than mild. And it's true, there's a real limit to the specific services that people can bill us for and we can pay for. And as people start to bump to that moderate, we're having this conversation with the counties to say, is this really somebody who should be getting services from the county? Yes, no. If they're not getting services from the county, are there other resources that aren't the very limited resources that we have that we should be availing ourselves of? So, but it tends to happen at a case-by-case level a lot now.
And real quick, because I really agree with everything both of you have just said, is that if a kid in a kid's program needed those services, they wouldn't be mild to moderate, they're covered by the counties. But if you're looking at someday potentially the behavioral health benefits coming back from the health plans, what the message I was trying to say is this is the opportunity to teach us everything you just said, that there's these services that in the commercial or the private world we're used to, and it's not going to meet the needs, and we're going to have to figure out a way to reimburse and pay for those services because they are good services and they are needed services. I agree with everything you both have said.
Okay, the last one, back there.
First of all, thank you all for being here. I think this is a really important discussion. I wanted to build off something that the gentleman from HealthNet said earlier, which is that maybe in hindsight there was a missed opportunity not to work with the counties on behavioral health before it became part of your responsibility. I thought that was a great observation. And today, a slice of behavioral health is still out there. So substance use disorder treatment, it's still carved out. It's not part of your responsibility, but it could be at some point. There's some conversations about that. So I was wondering, is there anything in your current work or future planning about coordinating with substance use disorder treatment right now?
I can tell you in San Diego County, where we've bragged all day about how collaborative we are, and I've got to be careful because we have the former head of our Alcohol and Drug Services, Susan Bauer, here, who's moved up within our Health and Human Services Agency. But we've met with our alcohol and drug services providers more than once. We now have them at the table with our behavioral health work group, just now getting into it, so we're way late. But I don't think we're any later than anybody else. We keep saying over and over and over and over how important this is, and it is, and then we have to start dealing with ABA and all these new benefits, and we forget about them again and again and again. It never stops. Same with expert screening, brief intervention, referral, and treatment. You know, we say it's important, and then all this new stuff comes up. So I agree, this is the opportunity. We need to do a way, way, way better job at getting to know the alcohol and drug service providers, because down the road, like everything else, it will probably somehow come our direction. Because one way or another, the state is looking at funneling all their dollars one way and then letting us pass it out instead of them. So I think it was an important question, and we're trying hard in San Diego. We're not doing a great job, but we will.
And the same is true in LA. I think the CalMedi Connect process, even though it's still the purview of the drug and alcohol departments, the CalMedi Connect process is driving that. And so both in San Diego and LA, we're doing that. And I think, you know, now that we are in this world for the Medi-Cal population, in the other counties, you know, sort of depending on the amount of volume that we have in a particular county, that's driving more conversations about, again, there's this crossover between if somebody's getting outpatient psychotherapy from a therapist in our network, and it turns out that person has significant drug and alcohol issues, what are they doing? Because there's nothing else that we have to offer. So what kind of linkage is happening? Does that outpatient therapist in that particular county, in that particular community, know the resources? If not, how are we gonna get that information to them?
Yeah, and just to add to that real quick, because I think the most important and the best thing we did that's helping us in San Diego County, and Susan was very involved with this, is, you know, we kind of put an end to having our mental health division, our alcohol division in two different worlds. And I remember like 15 years ago, when those two agencies in San Diego County were at one location in our coastal area and stuff, and I remember introducing their head of alcohol to their head of mental health because they didn't even know each other walking down the hall towards the cafeteria many, many, many years ago. I mean, it was weird. And now, I think it was 2 years ago, Susan, we've come under one umbrella, of course, and I know a lot of counties have, but not all. That's really a big step. So when we bragged earlier about training these 2,000 or whatever providers, where we're going out to these providers, teaching them about Medi-Cal, new benefits, and CalMedi Connect and stuff like that. What's really cool, especially in the last 6 months to a year, is for the first time ever, there's always alcohol and drug service providers in the room. So we're slowly, again, we're not doing a good enough job at all, but we're getting there. They're in the room, they're at the meetings. Within the last 6 months, I'd say for sure all the heads of alcohol and drug service contracts in San Diego County, they at least know who we are and what Help Me San Diego is and who the Medi-Cal health plans are, and they've been to a meeting or two. So it's a start. You know, we might be late, but we're probably no more late than anybody else. You know.
All right, well, thank you very much. I really appreciate the job our panel has done with the most interesting and presentations here. So thank you very much, and good job.